Are you ready to start, Carrie? Okay. Can I ask you to take your seats, please? Thank you. We might as well get started. I would like to say the reason why the lighting is the way it is this evening is because this is being webcast at the same time, which is quite an accomplishment for the college. Well, good evening. My name is Bob Scherer, and I am the current chair of the section on public health and preventive medicine for the College of Physicians of Philadelphia. On behalf of the college and the section, I'd like to welcome you to the program this evening. How many of you have been, is this the first time you've been at the college? Well, many of you have been here before. Well, a warm welcome to those who are here for the first time. Before we begin the program this evening, I would like to tell you a little about the college. It is a very valuable community resource because it is a place where all of the medical schools, medical institutions, and public health groups can gather to discuss important health topics. The college was founded in 1787, which is the same year that the United States Constitution was written, and 2 years before George Washington became our first president. It is the oldest medical professional organization in the country. And it's always been active in public health issues, beginning with the yellow fever epidemics of the 18th century and progressing up to the modern time. The mission of the college is to advance the cause of health while upholding the ideals and heritage of medicine. Tonight, we are here to advance the cause of health by bringing together the public health community to talk about a very important public health issue. This is an exciting event because it is the second citywide Philadelphia Public Health Grand Rounds. I'd like to thank Jim Bueller for coming up with this idea and for the program, and I'd also like to thank Dr. George Warwick, the CEO of the college, for helping to make it possible. Now, Philadelphia is indeed very fortunate in that we have a number of talented individuals with expertise in public health. We have 8 academic institutions that offer some formal training in public health, and we have several hundred students working in public health degrees. In addition to that, we have a number of governmental and non-governmental and voluntary agencies working on public health issues. If we can all work together on the important public health issues that affect our community, we will make an improvement in the health of our community. The moderator for the evening session, for this evening session, is Dr. Sara Kinsman, who is currently the director, the Division of Maternal, Child, and Family Health for the Philadelphia Department of Public Health. Dr. Kinsman has an MD and a Master's in Science in Clinical Epidemiology from the University of Pennsylvania School of Medicine and a PhD in Sociology from the University of Pennsylvania. She is trained in pediatrics and adolescent medicine at Children's Hospital, Philadelphia, and she is board certified in pediatrics and in adolescent medicine. I'm now going to turn the program over to her, who will introduce the speakers for this evening.
Good evening, everyone. It's a pleasure to be here and to see you all this evening. The speakers tonight are incredibly excited to be bringing you their knowledge and expertise, and I'm really excited to be able to have put this together. Can you hear me now? Great. Okay. Thank you. First, I'd like to say some thank yous to the College of Physicians of Philadelphia, Dr. Scherer. He's been an absolute supporter of public health information and sharing throughout the city. The College of Physicians of Philadelphia has brought this together along with the Philadelphia County Medical Society and the Philadelphia Department of Public Health. I feel bad there's a ring. You guys okay? Is that better? I just want to be sure you can hear and not have a ring. Okay, good. This is an effort that came out of the Philadelphia Board of Health under the direction of Dr. James Bueller, our former commissioner. Dr. Bueller was interested in ensuring that women in Philadelphia had access to very effective contraception, and with the support of the Board of Health, asked us to present the information about clinical issues related to LARC and some of the barriers to access. And so I really want to thank Dr. Bueller and the Board of Health for bringing us here today. I also want to thank providers throughout the city who have been working for years and years to increase access to highly effective contraception. So tonight is a culmination of many OB chairs work, other advocates, midwives, nurses, and folks who are interested in really improving women's health throughout the city. And it's not just women's health, it's improving the whole economy of our city, and I'll talk about that in a moment. And finally, and most importantly, I'd like to thank women in Philadelphia and their families who've put their trust in us to provide the best care available and possible for them. I'm first going to start by introducing the Grand Round speakers, and then after that I'm going to give a little overview about where we stand as far as reproductive health issues in this city and why the Division of Maternal Child Family Health is so interested in this area. So, let me start with introductions. As I introduce folks, they'll stand up so you know who I'm going to talk about. Dr. Aletha Akers is the medical director of the Adolescent Gynecology Consultative Services at the Children's Hospital of Philadelphia. Dr. Akers attended Bryn Mawr College, received her medical degree from Johns Hopkins University, and completed her OB-GYN residency at the University of Michigan. Dr. Akers was a Robert Wood Johnson Clinical Scholar at the University of North Carolina, Chapel Hill, where she earned her master's degree of public health. Dr. Akers' research focuses on the social determinants of adolescent reproductive decisions. Her talk is entitled "The Promise and Perils of LARC Use Among Adolescents." So that's where we'll start this evening. Our next speaker is Dr. Courtney Schreiber. Dr. Schreiber is the director of the Penn Family Planning and Pregnancy Law Center at the Hospital of the University of Pennsylvania. Dr. Schreiber attended Columbia University, received her medical degree from the University of Pennsylvania, and completed her OB-GYN residency at the Hospital of the University of Pennsylvania. Dr. Schreiber was a fellow in contraceptive research and family planning at the University of Pittsburgh, where she earned her master's degree in public health. Dr. Schreiber's research focuses on reproductive epidemiology and family planning. Her talk this evening is entitled "Access to Highly Effective Postpartum Contraception. The Time is Now." Our third speaker is Melissa Weiler Gerber. Attorney Weiler Gerber is the president and CEO of AccessMatters. AccessMatters' mission is to close gaps in service and to achieve better health outcomes at local, state, and federal levels. Attorney Weiler Gerber graduated magna cum laude from Princeton University. She received her law degree from Georgetown University. Attorney Weiler Gerber has been president and CEO of AccessMatters since 2010, and prior to that was the executive director of Women's Way. Her talk tonight will be entitled "Reimbursement-Related Barriers to LARC Access." So let me start by laying the groundwork in Philadelphia. So reproductive health is important for women, it's important for families, and it's important in changing the demographics of poverty in this city. And let me show you why. So let's start with looking at births for teens, 15 to 19 years, by race and ethnicity. And this data is from 2003 to, 03 to 12. And what we see here is, the good news is that there is a decreasing in the number of young women who are giving birth in our city. Having said that, if you look at the top line, in the orange, you'll see that for Latina women, 77 out of 1,000 women give birth in our city. The line below that's red shows that 59 of 1,000 African American women give birth, and 47 overall. So the trend is going down in Philadelphia, but if we compare our data to national statistics, you'll see we are way higher. And those averages and the trends should be moving down much more significantly than they are. Now, the picture gets even more complicated and serious when we look at where teen births are happening in the city. The highlighted box in the middle shows that 97.6 out of 1,000 women in lower North Philadelphia and Philadelphia in North Philadelphia are giving birth. That is an incredibly high number. So we have some really focused work to do throughout the city. If I were to overlay the map of poverty, it would overlay with teen birth rates. Let's talk about birth spacing and higher order births. Inter-pregnancy intervals of less than 18 months. So the CDC suggests that ideally you would not have an inter-pregnancy interval that is shorter than 18 months. Now nationally, a lot of folks do have a child before that time. But in Philadelphia, we see some areas, particularly in lower north and moving up north, the orange areas, that are very high and higher than we'd like to see. Of note, the Center City area has a very small sample size and may have some older cohort of women, so those birth intervals might be a little bit smaller. So that's why you see red in the center. But what we see is a large part of Philadelphia is in orange, and we don't want it there. We want to see it in green. That means you have one child after another child. Higher order births, or births that are 5 or greater. Now we know a couple things about when women start to have their third pregnancy. Not only do they say it was unplanned, but they actually are much more likely to say it was unwanted. Now we're not talking about third pregnancies here, we're talking about 5 or more. And what we know is some women, not all, would want to be able to plan those higher order births. Here in our city, 6.2% overall of births are higher order. For Black women, it is 8.4%. So we have a lot of women who are having more births than they might have wanted to have. When we look at the areas where there are a high proportion of higher births, as you can see in lower North Philadelphia, approximately 10.5% are higher order births. What does this all mean? Well, it means that reproductive health can impact intergenerational opportunity. Unplanned pregnancies related to births to teens, repeated births to teens, close birth spacing, and having 5 or more children are challenges. And the challenges that are associated with those are impact maternal and infant health, impact child emotional and cognitive development, impact neighborhood mobility, the ability of a family who wants to give their child opportunity and move to a higher income neighborhood. And finally, intergenerational economic mobility is significantly impacted by reproductive health. I am going to turn our evening over to our speakers who are going to delve into this issue more depth. And after each one of them has had a chance to present to you all, we will have a discussion session. The next speaker will be Dr. Aletha Akers, The Promise and Perils of LARC Use Among Adolescents.
Is this on? Can you hear me?
Nope.
Hold the microphone.
I've actually got a mic that's on. Is this on? Wonderful. Well, good evening. Thank you for the opportunity to speak with you, and I want to thank Sara for that fantastic introduction. So as Sara mentioned, each of us is going to speak with you this evening about a slightly different aspect of the problem that she mentioned. And what I'm going to talk with you all tonight about in a few minutes is really the promise as well as the perils of using long-acting reversible contraceptives in adolescent patients. And I want to start by saying briefly what LARC methods are. So they are safe, highly effective birth control methods that can be used continuously over the course of several years to prevent pregnancies in women. And I'll go into a little more detail more specifically about the different options. So my goals for this evening are several-fold. One, I want to tell you a little bit more about LARC methods and some of the similarities and differences between them. I also want to talk with you a little more about their potential for really reducing teen pregnancies and particularly unintended pregnancies amongst our adolescent populations nationally as well as in the Philadelphia community. But I also want to be able to talk about some of the special considerations and some of the barriers and challenges to their use in this population. And I'm going to consider issues of counseling and delivery of services as well as issues at the level of payers and actually conducting the insertion procedures. And then I really want to wrap up by sort of highlighting some of the ongoing debates about the potential for using these methods in this population. And my hope is that when we do our question and answer session at the end, to really invite some deeper conversations about how we can strategize to really improve access to these services for adolescents in our city in order to improve their outcomes. So I want to just highlight my funding disclosures. These are some of the foundations and other sources that are funding some of my research and programmatic work at the Children's Hospital of Philadelphia. So I want to start by sort of re-encapsulating sort of what exactly is the public health problem that we're talking about here. And so the main issue is that teen pregnancies are a problem in the city as well as in the nation, as Sara kind of set us up to talk about. While rates of teen pregnancies have actually been declining pretty significantly in recent decades in this country, they really remain substantially higher than where we'd like to see them. And that becomes evident if you compare sort of what our national teen pregnancy rate is here in the United States to rates in other Western developed countries. And you'll see pretty quickly that our rates are much higher compared to some of our comparative peers. So what exactly are LARC methods? I want to take a couple of minutes just to sort of make sure we're on the same page about what we're talking about. So LARCs are actually medical devices. Many people have heard of birth control pills. LARCs are actually medical devices that can be used to deliver either similar types of hormones to, say, pills, or maybe non-hormonally based. But they're devices that can be placed either inside a woman's uterus or womb or placed under the skin of her arm that can work over a long period of time to prevent pregnancy. And they primarily work by preventing an egg and a sperm from meeting and therefore forming a baby. And all of these methods, as I mentioned earlier, have been demonstrated to be safe and effective with a failure rate of less than 1%, which is actually better over the long term than sterilization. So what are the different types of methods? So you have intrauterine devices, and we have our subdermal contraceptive implants. So some in the uterus, some under the arm. In our category of intrauterine contraception, there are overall there's 5 types. There are 4 types of IUDs, one that does not contain any hormones, and 3 other devices that do. There is one form of subdermal implant. And I want to say there are lots of different options, but in terms of sort of what's the right option for any given woman, really is something that's determined in a long discussion between that woman and her provider based on what that woman's pregnancy plans are, what her menstrual history is, and what her other medical conditions may or may not be. But we should keep in mind that there are lots of different birth control options out there. So why is it that people have been focusing a lot around the potential use of long-acting reversible methods as a way of reducing teen pregnancies? And the reason is this: if you look at this slide, it's really laid out so that you can see on the one side at the top what are our most effective methods, and on the other side of this slide, the less effective methods. And essentially what you see is that our LARC methods, our implants and IUDs, are amongst the most effective methods that we have. And in the area kind of in the middle where you see the small people, that shows you out of 100 women, how many women who are using this device in 1 year might potentially get pregnant. And you can see that only about 1, and it's actually less than 1 per 100 women might get pregnant at the end of a year if they're using our LARC devices. Compared to women who may be using a contraceptive pill patch or ring, where about 10 out of 100 women might get pregnant, compared to things like condoms, where about 20 out of 100 women might get pregnant. And the main reason for this difference is really that our LARC devices, once they're placed, they're what we call forgettable, in that you don't have to think about them anymore, you don't need to go back to the doctor, they will work continuously. So because of this, these devices have really been endorsed by multiple health organizations throughout the country as being options that should be considered first line for women, either adolescent or adult. I also want to take a moment to mention that these devices can be used for many other things, not just for contraception. So they may be used for other types of family planning, such as birth spacing. So women who do want to have more children, but they just want to delay the interval between children, as Sara mentioned. They can also be used as emergency contraception if a woman has had either sexual intercourse and consensual sexual intercourse and not been using another method, or non-consensual intercourse and would like to avoid a pregnancy. But they can also be used for managing menstrual problems, or in select patient populations for whom, because of medical reasons, they can't use some of our other available options. Or for example, women who may have cognitive or physical disabilities where they want a method where they don't have to be using something every day, or they may not be able to take a pill every day. But for the purposes of this talk, we're really going to focus on their use as contraception. And since we're talking about teens, then it's important that we think about sort of what is the need. And one way of thinking about this is thinking about how prevalent is sexual activity amongst teens. So this slide is really designed to show that. And you can see that very few teens are sexually active at younger ages, but around the age of 14 or 15, you really start to see a linear increase. And if you looked at this slide across many of those other Western developed nations, whose rates of teen pregnancy I showed you earlier, the graph would be the same. Where we differ is in our rates of teen pregnancies and births. Another way of thinking about what is the value or need in this patient population is really to think about, of all pregnancies in the US, what proportion are actually due to teens? And what may or may not surprise you is that if you actually look at all births or all pregnancies among women by age, the proportion that's actually due to teens is actually not disproportionate to the number of teens that are in our patient population. So around about 15% of all pregnancies are due to teens, and teens represent about 15% of our population. But if you look at unintended pregnancies, this is where you see the big difference. The vast majority of pregnancies in teens are unintended. This is where our public health problem lies. So these pregnancies are occurring in young women who do not wish to be pregnant, and we have access to methods that can really prevent this from happening. So I'm not going to spend a lot of time here because Sara kind of covered some of this, but this is really just to sort of say what's our need in Philadelphia relative to the nation if we're thinking about unintended pregnancies. A little more than half of all pregnancies in the country are unintended. It's approximately the same in Pennsylvania, which spends about $700 million each year in costs related to unintended pregnancies overall. And our issues in terms of teen pregnancies amongst individuals age 15 to 19 are pretty substantial compared to the national averages, as Sara highlighted. And Sara also demonstrated this. We have significant racial and ethnic disparities in our city, with African American and Hispanic teens disproportionately affected. All rates have been coming down, however, the rates remain significantly higher in this group. So then the question becomes, given their forgettable nature and how well LARCs work as contraception, how often do adolescents actually use LARC methods? And the answer is not often. So about a little less than half of all teens between the ages of 15 and 19 have ever had sex in their lives. But the good news is that about 4 out of 5 of them actually use a contraceptive method or report such the last time they had sex. That's great news, and that's something to celebrate. But on the downside, very few of them are actually using our longer acting methods. So they tend to be using far less effective methods. In a study that looked at this patient population, when they were attending Title X funded clinics, so clinics that have lots of family planning services available, such as the availability of LARC methods, we can see that over time, the proportion of youth who are using these methods has been increasing, which is fabulous, but it still remains only around about 5 to 7% of youth. So what methods are they using? So if we look at the different types of methods that are available, we see that teens tend to be using the least effective methods. So they tend to primarily be using condoms, which essentially means that the vast majority of the time they think that their partners are using them, because most of the condoms that are used are male condoms. About 60% of them report primarily using withdrawal, which is not very effective. Or they're using some of our other methods, which have decent rates of effectiveness, but certainly not as effective as our longer acting methods. So what might happen if LARCs were more widely available to our teens? Well, there are 2 studies, the data for which have come out in the last few years that really answer this question. One was a population-based study that was done in the city of St. Louis, where contraceptives, including LARCs, were made available for free to women in the city. About 10,000 women chose to make use of this service, about 1,500 of whom were adolescents. And what they found was that almost 75% of those teens chose a LARC method, and almost 90% of them were continuing to use those methods at the end of 2 years. So substantially high uptake when cost and access barriers were removed. And what they found as well was that the rates of both teen pregnancy as well as rates of abortions among teens dropped substantially amongst the adolescents that use these services. And that was relative both to other teens in the city as well as compared to the national averages. As a result of that, the anonymous donor who funded that project then went on to fund a similar program within the entire state of Colorado. And what they found was very similar results. So they found that they were able to basically drop the birth rate among teens by about 40%. Specifically, the drop in teens aged 15 to 19 was 48%. They also saw a significant decrease in a slightly older cohort of young women between the ages of 20 and 24. And also a significant decrease in the number of teens having repeat births. So a tremendous benefit. So it sounds like these might be sort of the holy grail, right? Why don't we use them? Seems like this would be the perfect answer to many of our issues around this public health challenge. Well, there are lots of reasons, and I don't have time to go into a ton of detail about each of these, but I wanted to take a moment to really highlight that there are a variety of challenges to really making these services available to teens. There are issues at the level of the teens themselves, providers, the health system, as well as payers. And let's look at a couple of these. So teens. So we have issues in terms of teens' knowledge and attitudes and beliefs about these methods. So a lot of teens don't know that these are options for them, or they may hold a lot of fears around using these options. There are lots of developmental considerations. So teens are often less tolerant of side effects for any medications as well as contraceptives. They may have a more difficult time understanding the risks and benefits of their use, more difficulty kind of developing a long-term plan and thinking abstractly about preventing something that's never happened and may happen in the future. And they may be much more idealistic and concrete in their thinking about their risk for pregnancy. In addition, teens are very much influenced by their peers and their parents and other social reference and kind of what they may have to say. And based on some work that was done actually through AccessMatters over the last 5 years or so with a CDC-funded grant, we know that attitudes towards these methods amongst young people and their families in our city are highly negative. So we have a lot of work to do in terms of improving receptivity to using these methods. And then there are a number of issues at kind of the health system level. And so within the context of clinical practice, when I see youth, there are lots of things that I hear them say that really sort of encapsulate a lot of these different issues, right? You can't get pregnant the first time. I'd rather have a baby than have cramps. I start something when I start having sex again, or I just won't start having sex again. So we have many barriers cognitively and developmentally that really can impede these products' use. There are provider considerations. So there are a lot of providers, pediatric providers, who see these patients on a regular basis, who don't really know about LARC methods. They don't know that they're considered first line. They don't have the skills for placing them, and they may not feel comfortable managing any problems or issues with these devices once they're actually placed. So there's a lot that has to be done in terms of educating providers and/or providing opportunities for them to be trained to be able to provide these services to their patients. At the level of the health system, there are a variety of barriers. There's generally finite time available within a clinic visit to see a patient and provide all the services available. And counseling adolescents and their families can be very time-consuming about these particular methods, and that increased complexity is not reimbursable, at least not at the moment. In addition, placing these devices in adolescents, particularly our intrauterine devices, can require a lot more time and a lot more staff resources, which is also not easily reimbursable. There are confidentiality issues in terms of documenting these services in the charts. And there are also a lot of issues, particularly at the level of pediatric institutions, in terms of being able to actually access these different devices and make them freely available within the context of sort of pediatric care. And then there are some key issues at the payer level, and Melissa's going to talk a little bit more about these, but in short, although adolescents have access to these services confidentially, if they access them through their family's insurance plans, that may actually compromise their confidentiality because insurance companies' explanations of benefits that go home may disclose that adolescents use these services, which means a lot of adolescents may be interested in using these, but it means they would then have to pay out of pocket in order to actually access them, or travel to clinics that have funding to provide these devices for free, which can be really complicated for teens to actually make use of. There are other issues in terms of institutional contracts. So I've been a provider at a pediatric hospital now for 2 years after spending my career in women's hospitals where we freely place these devices in women. But I have learned that there are a lot of challenges in that many pediatric institutions have never placed these devices, and their contracts with their payers may not be set up to allow placement to actually happen easily. So there's a lot of work that needs to be done there as well. And a big problem is that these devices are expensive. They can cost between $600 to $900, particularly if you have to pay out of pocket for them. And so they are incredibly expensive to be able to access. There are a number of programs that can help, but this is a major barrier that also needs to be addressed. But what's the savings? So in that Colorado project, what they found was that when they used these devices in their patients, what they found was that for every $1 spent in that program providing access to long-acting contraceptives, their state Medicaid program could have saved almost $6. So there's a tremendous potential for savings here. As a result of that, the state of Delaware recently decided to partner with a private organization that is trying to make access to these products easier in clinics that haven't traditionally provided them. And they made that decision after recognizing that the rate of unintended pregnancy at the state level is significantly higher than national level, at almost 60% of pregnancies in the state being unintended. And given the findings of Colorado, they decided that it was a wise financial investment to try and make this available. But so what would be the downside? Well, there's been a lot of debate nationally about the fact that teen pregnancy is really just the tip of the iceberg. When you have a teen who's pregnant, that's generally the downstream effect of many other things having happened. And as Sara pointed out, oftentimes what we're talking about is teen pregnancy really being the confluence of lots of other issues, such as limited education, housing and discrimination issues, issues of housing instability, lots of other really social determinants of health that are going on. And so LARCs really are one way of tackling this problem within the context of the healthcare system. But more broadly speaking, if we want to see our rates really improve to be comparable to our other countries that are sort of similar to us, this is really going to require that we do a lot more work at a societal level to really address many of the other aspects of this problem that are really contributing. And so in summary, I want to say that LARCs are safe. They're a very effective option for preventing pregnancies amongst teens. But supporting their use in adolescents really requires that we pay attention to a number of things. Adolescents may need a different approach to contraceptive services than our adults, but it also requires a change at the level of the way our healthcare system functions to provide care to adolescents, as well as in the policies of our insurance companies. But it also requires that we think really critically about issues related to individual versus population health, as well as issues of really social justice. So with that, I want to say thank you very much for your time this evening, and I look forward to questions and comments, which I think we're taking collectively at the end, correct? Okay, thank you.
So nice.
Good evening. Thank you all for being here. We're all here this evening because we care about the health of women and families in Philadelphia. Here are my disclosures that also support my work for the health of women and families in Philadelphia, so I'm very grateful to my funding sources. So, as you've been hearing so far this evening, unintended pregnancy is a major public health problem, and when you think about it, a healthy start to life begins preconceptionally. The problem is when a pregnancy is unintended, that really puts women and their children at a disadvantage. And in a country where more than half of pregnancies are unintended, we are starting with a handicap. In Pennsylvania, we have higher than that number nationally. We have 53% of pregnancies are unintended. And 51% of these pregnancies and the births resulting from these pregnancies are paid for by state Medicaid. As the speakers prior to me highlighted, this is a disparities issue. Unintended pregnancies disproportionately affects poor women, but it also keeps poor women poor. And we have got to intervene to correct this disparity. That's why I want to spend the next few minutes of your time talking about what I think is really an opportunity and focusing on the prevention of the second birth and rapid repeat birth with postpartum access to long-acting reversible contraceptives. The postpartum period really provides a unique opportunity to have a public health impact for several reasons. First of all, it may not surprise you based on what Dr. Akers highlighted, that being an adolescent is actually an independent risk factor for rapid repeat birth or short inter-pregnancy intervals. Once you start becoming pregnant in quick succession early, it is very difficult to pull yourself out of poverty. And as we see, there are also special public health problems associated with rapid repeat birth. For example, there are socioeconomic problems that affect women who have rapid repeat births and teens who have 2 or more births by the time they're 30. So that actually gives them a nice stretch of time. But still, if they have 2 or more births by the time they're 30, they are more likely to forego education and continue to live in poverty than those who can space their pregnancies better. And also there are adverse birth outcomes that are independently associated with short inter-pregnancy intervals. If a woman has a 12% chance of having a preterm birth with her first baby, with her second delivery, she now has a 17% chance of a preterm birth if that is a short inter-pregnancy interval between those 2 pregnancies. Preterm birth in and of itself is a major public health problem in our country, and we have an intervention that may be able to help correct this problem. But child spacing requires work and it requires planning. What do we tell our patients right now as providers of obstetric care? Well, we tell them to hold off and delay resumption of sexual activity until their 6-week postpartum visit. But many folks don't delay their resumption of sexual activity until this time. And often the people don't even make it to their 6-week postpartum visit when they may be told this is your opportunity for contraception. If a woman is not breastfeeding, she'll ovulate as early as 25 days after a delivery. So if she doesn't have contraception on board, she's at risk of another pregnancy. And if she is breastfeeding, well, the lactational amenorrhea method, what that requires is frequent intervals of suckling at the breast in a 24-hour period. Not sustainable necessarily in our modern society. The breast pump has never been studied. We don't know if that has the same contraceptive efficacy as the traditional lactational amenorrhea method. So these women are probably at increased risk of pregnancy without contraception as well. Well, birth control can help prevent unplanned pregnancy and reduce the risk of rapid repeat birth. But not all methods of contraception are equal, as you've already seen this evening, but it's an important point to drive home. If you were treating somebody for hypertension, would you choose the method that was going to reduce their risk of stroke by 1 in 100 or by 10 in 100? We really need to focus on the most effective methods if we're going to consider the public health impact of our decision making. And LARC users have 4 times the odds of achieving an optimal birth interval than women who are using less effective methods. So as a child spacing instrument, LARC methods really work. LARC method continuation rates exceed other methods. This is part of the reason why they're so good for child spacing, because women do continue them for longer durations than they do pills, patch ring, condoms, or other methods. So what are we talking about with immediate postpartum LARC? Generally, the convenience here is that the LARC methods fit what we're looking for in a postpartum contraceptive method. These are progestin-only methods. They don't have estrogen, so no increased risk of thromboembolism in the postpartum period, and no interaction with breastfeeding. Or they're non-hormonal methods, so the hormonal issue is not of concern. It's a convenient time for patients to provide them with this highly effective method of contraception before they leave the hospital after a delivery. It helps to assist with healthy birth spacing, and study after study show that this is a safe time to provide highly effective contraception before women leave the hospital after a delivery. There are issues to consider with the 2 different types of LARC devices. For the implant, this can be placed at any time before hospital discharge, and there is no concerning effects on maternal health or breastfeeding outcomes because it's a progestin-only method. For the intrauterine device, a little bit more tricky. Studies have shown that the optimal time of placement is within 10 minutes of placental delivery, but it can be placed safely after either vaginal delivery or cesarean section. Now, more data are needed on risk of expulsion, but as I'll show you later, there are ways to mitigate that risk of expulsion, and it's still cost effective even if when expulsion rates are higher than they are when placed outside of a birth situation. So I show you these data here to highlight the example of that immediate postpartum LARC are highly desired by women. This comes from a trial that we did at Hospital of the University of Pennsylvania, actually with enrolling adolescent women in a larger trial. We asked 100 of these women at the time of their delivery what method they were desiring for their postpartum birth control. And then we asked them 6 months later what method they were using. So you can see I highlighted the LARC methods in red, and 24% of women requested to use an implant, and at 6 months postpartum, 25% were using an implant, so that was pretty good. When you look at the 2 hormonal methods, the 2 intrauterine devices together, 33% of women were requesting an intrauterine device. Now at this time in my hospital, we were not providing immediate post-placental IUDs to our patients. If you wanted an IUD after delivery, a woman had to come back at her 6-week visit to receive that IUD. Well, look what happened at 6 months. 0 women who elected to use an IUD were using IUDs. And also, if you look down a little bit further here, not many women cited that they planned on using withdrawal or condoms as their chosen postpartum contraceptive method, but at 6 months, many women were using these less effective methods, and I'm sure that most of those were women who wished that they were using IUDs but hadn't been able to make it to yet another visit with an infant at home to have that intrauterine device placed. These right here, these are our rapid repeat births. Postpartum implant continuation rates are high, so women choose them and women continue them. These data also come from our hospital of the University of Pennsylvania, showing very high continuation rates of all comers. So these were all women of all ages who chose to have the implant placed after delivery before hospital discharge. At 1 year time, almost 90% were still using their implant. By 3 years time, which is the full duration of use, almost 70% were still using their implant. So very few discontinued early, and probably many of those people discontinuing at 3 years or a little bit before were planning to have another pregnancy. That's appropriate use of birth spacing contraception. This refutes the myths that women may choose them and not continue them. And many of the concerns with these very expensive methods, as you heard, is that women may not use them, sort of get their money's worth out of them. But here you see very good continuation rates in the postpartum setting. We know that timing is critical when it comes to contraception. Women are busy, they have many demands on their lives. We need to make it accessible to them when they want it and in an appropriate setting for them. ACOG agrees. They say the immediate postpartum period is a particularly favorable time for IUD or implant insertion. And women who have recently given birth are often highly motivated at this time. So what are our barriers? Well, the main barrier for postpartum LARC delivery is insurance payment. It's actually a little bit tricky. So despite the fact that most agencies endorse the use of immediate postpartum LARC and data support its safety and efficacy, many Medicaid policies do not have a payment mechanism to reimburse for LARC in the inpatient setting at all, and particularly in the setting of a delivery. There are only outpatient billing codes for LARC methods. So because most obstetric fees are paid in a bundled fee, there need to be additional billing codes provided for these expensive devices and the additional time that's required. Insurance companies will tell you that cost effectiveness remains a concern. Why should they pay for these devices? But postpartum LARC are cost effective. We know that the immediate postpartum implant can save thousands of dollars. And we also know from data from Indiana that for every dollar spent on an intrauterine device, they modeled that they saved $3, and that the cost effectiveness continues actually all the way up until expulsion rates of 50 to 70%. So even with this concern of increased risk of IUD expulsion, the method is cost effective. So here we're talking about methods that women are asking for, are safe and effective for women, are a major public health win, and also can help us with saving money on a state level. This is a win-win situation. 19 state Medicaid programs now do reimburse for contraceptive devices placed immediately after a birth. So we've actually seen a lot of movement and tremendous success across the country. They have all different ways of doing this depending on the state. Some provide a credit adjustment, and others allow for modifiers to be added to the delivery charge. CMS is fairly liberal. They're in complete support of this. All they require is that LARC be an add-on benefit to the DRG code for the delivery, that bundled code for billing for a delivery, and that hospitals use appropriate billing mechanisms and coding. We can do this, Pennsylvania. So here we have it. It's the yellow brick road to reducing rapid repeat births, reducing the preterm birth rate, reducing our levels of poverty, and helping to accelerate women to where they want to be. I look forward to hearing your questions during the question time. We don't need our patients to look like this. I mean, the poor woman, right? We can do better parenting through postpartum contraception. We can have patients look like this. Postpartum LARC is the first choice for many women. It provides safe, effective, long-lasting contraception that's totally reversible, allows women to have adequate birth spacing. We can fight this barrier of reimbursement and simple logistics that are preventing us from delivering the best care to our patients. Many other states have shown us the way, and Pennsylvania can follow this example. Thank you very much.
All right, the folks here from my staff will know that that was the most terrifying part of this for me. Now that that's up on the screen, it's all good. So I want to thank everyone who was involved in making tonight's program come together, and just repeat what the prior speakers have said, that we're here because we're incredibly passionate about the potential of LARC for really impacting, finally, a very stagnant unplanned pregnancy rate in our country, and particularly for teens. You've heard all the convincing science, you've seen tremendously compelling stats, and so why isn't there greater uptake? And I think our prior speakers have really hinted at the fact that whether we like it or not, whether we're comfortable with it or not, yes, we can dismiss some of it to barriers that have to do with our community's education and knowledge, which we are working on even as we speak. We can attribute some of it to providers needing to have better education, but like it or not, a lot of this does come down to dollars. It comes down to cost. And so while in some ways I have the unsexy position of giving you a little talk on reimbursement that underscores some of what Corey was just telling you about, it's a very appropriate role for AccessMatters because we serve as the hub of a network of Title X providers. And what we try to do is to really advocate for standards of care and really to help them to be sustainable practices to provide services to those most in need in the community. And what we hear time and again is that this cost factor is really an issue for them. So last week, as I was getting ready for this discussion, out of the blue, I got an email from a colleague who used to be here in Philadelphia and who was working with someone, an OBGYN in a central part of Pennsylvania, who was feeling really frustrated and needed some help. And I thought that her story drove this point home so clearly that you can believe in the science, you can be passionate about the cause, and you can still not figure out how to get through the current system. So I wanted to share her story. She's an OBGYN affiliated with a hospital in central PA. She's a champion for LARC access at her institution, and she is so frustrated. In the fall of 2015, she obtained approval from her facility administration to initiate an immediate postpartum LARC program, and she was elated. She was directed to contact the inpatient formulary there to add the implant to their formulary. That's what they were going to start with for their LARC program. But her Pharmacy and Therapeutics Committee considered this, looked at the cost analysis, and decided that that device shouldn't be added or stocked at the hospital pharmacy because there was just too much projected potential monetary loss to the hospital. So then they explored whether the outpatient hospital pharmacy could stock it, and despite an enthusiastic director there, the determination was also no. She went to the physicians in the other states that Corey mentioned and tried to get some advice from them. And they used a sample of 2 of their patients and tried to provide them with prescriptions so that they could go during their 3rd trimester, get their device at the local pharmacy, and then bring it with them to delivery. I love this image, by the way, of your water breaking and you have to say like, oh, I need to stick the LARC in my bag. Like this is crazy to me, but having been there, but make sure your LARC's in your bag. So in any event, the local pharmacies couldn't fill the prescriptions because there were new requirements by the device manufacturers that only specialty pharmacies could be used for the devices. So she's now trying to work through those specialty pharmacies to have the devices sent to the office at 36 weeks, and then the patient would still be responsible for bringing them at the time of delivery. And she told me she's even considering whether residents could run over to the office, get the device while the woman was in labor, and bring it back. This is not a doctor easily deterred. She knows what her patients want, she knows what's the best standard of care, and currently she's spending all of her time trying to come up with workarounds because of reimbursement policies that simply aren't allowing her to do her job and allowing her patients to get what they want. And that's what this is all about. So I'm going to talk a little bit about existing policies that have come into play in the last couple of years that increase access to LARCs, some promising developments we're seeing across the country and in our region, some of the challenges, including and focusing on reimbursement challenges, and looking at how policy change can help really to bring forward our vision for Philadelphia. So first, existing policies that increase access to LARC. So obviously we know that the Affordable Care Act, which came into play in March of 2010, did a tremendous amount to help expand access to lots of care, including contraceptive care. It requires health plans to cover preventive services and eliminates cost sharing for the same, and that's clearly very important in the case of contraceptives, where research has shown to us that if there is cost sharing in place, it can be a tremendous barrier. You need consistent use, you need to be able to access it, and for these expensive devices, obviously this is a big issue. So insurance companies have to cover at least one type of all of the currently 18 FDA-approved categories with no cost sharing. There's some further clarification that came out in May 2015 that I'm going to talk about in a second. And the mandate is to cover the devices, the insertion, and the counseling. And the latest date for plans to come into compliance with this, because of grandfathering, was August 1st, 2012. So that further clarification was needed last spring because, maybe not surprisingly, there were some insurance companies that were slower to come around and really provide full access, and the federal government, and this was released both by the Departments of Labor, Health and Human Services, and Treasury, released a series of FAQs to really preserve the spirit of this provision and show what they meant by full access. So under this clarification, they made it clear that all the plans have to cover at least one form of contraception in each of the FDA-approved methods. So that means including the copper IUD, the IUD with progestin, and the implantable rod. And that coverage has to include clinical services, including patient education and counseling, which is the speakers before me emphasized is critically important with LARC insertion, and especially in the adolescent population. And if the provider makes a determination of medical necessity with respect to a certain method, that could be based on side effects, it can be based on differences in permanence or reversibility, or whether they feel a patient might adhere better to one method or another, the plan, importantly, must defer to the provider and provide that method without cost sharing. Now, insurance companies can still use something called reasonable medical management to be able to steer folks to one particular brand or type of device within each of those 18 categories, but they have to provide at least one no-cost sharing device in each of the 18. So now the focus is really for a lot of advocacy groups to make sure that we're monitoring what reasonable medical management is happening out there and to make sure that that is not also becoming a barrier to care. So as Corey mentioned in her talk, there is a lot of reform happening out there already. It is not as though Pennsylvania doing this would be putting us in the absolute forefront. In fact, there's tremendous building momentum. We talked to the Board of Health in Philadelphia back in July, and there were 12 states listed on that list. Fast forward just a few months, there are now 18. So there is tremendous momentum to move in this direction, and we'd like to see the letters PA added to that list of abbreviations as soon as possible. So as was mentioned, what's really happening with this state Medicaid reform is correcting the current issue with bundled rates. So hospitals are currently reimbursed under Medicaid managed care with a bundled rate for a delivery. So anything that happens in that delivery room is captured in one bundled rate. That sounds simple and efficient, except that most of those rates were not negotiated with LARC insertion in mind, and LARC takes time both for the insertion and the device itself, as you've heard, is quite expensive.
So right now, in an inpatient setting, there isn't a way for a hospital to recoup those costs. They can try to go plan by plan, hospital by hospital, to different payers to renegotiate this rate. But that's not a very effective way to do it. It's not efficient, and it is very unlikely to succeed in most cases. So what is happening now is what you would want to be able to do is take the codes that can be used in an outpatient setting, where you're saying to the patient, sorry, you're going to have to come back 6 weeks later and do it in my office. You want to be able to take those same codes and have them recognized and reimbursed in an inpatient setting. Now, that's really important because other tools that can be used, like the 340B discounted device and drug program, only applies to outpatient insertion. So a hospital doing this inpatient can't take advantage of that program, and hospitals simply can't absorb the costs otherwise. These are too costly, and you'd like to make them available to any patient who wants them. And the argument that we've really tried to make is, we're not really asking for new dollars to flood into the system. This is really cost neutral to a system that's already paying for these in an outpatient setting. The argument could be made that this will increase utilization, but as I think you have heard, inserting these devices versus having unplanned pregnancies and at many times high-risk pregnancies is a very cost-effective thing to do. So why is this important? Here I am standing here leading the organization that's the Title X grantee. Why can't Title X solve this problem? Isn't that what Title X is there for? Well, that would be lovely if Title X was adequately funded for all the unmet need in our region and in our country, but Title X has actually been funded it has had its worst 5 years over the last 5 years, which I always joke are my 5 years in this position, and I picked an excellent time to come here, but Title X really has been subject to relentless cuts. And so we have to really see that federal funding, while it is available, is really a last resort to get this kind of coverage. It can cover the full range of contraceptives, so for those organizations that work with us in our network, they absolutely can use this funding to support LARCs, but the bottom line is it's not enough and it shouldn't be the answer when we have a simple policy change that can be a sustainable way of making this available. Now, I must say there are two pieces to the advocacy we need to do, because this is a chart which I know is tiny, but it's a recent comparison that Guttmacher Institute did to look at whether providers who are putting LARCs in place are recouping their costs. And what you will be able to see is that no one is really recouping costs, whether it's commercial insurance, whether it's Medicaid fee-for-service, or whether it's Medicaid managed care. But what I'll say is Medicaid managed care, the system we have here in Pennsylvania, reimbursed at the worst rate in terms of getting LARC costs covered. So first, we've got to get them covered, and then we absolutely simultaneously need to be working overall on general reimbursement rates if we want to be able to have providers in our community continue to be available to provide care to the folks who need it most and have the least to pay for it. So promising developments. This has been such an important issue, with reimbursement so trumping what we know to be best practice, that a number of very prominent organizations like ACOG, the Bixby Center, the National Health Law Project, NIFRA, and the National Women's Law Center have put together an entire guide to help providers navigate this territory. In addition, we have folks like NIFRA, the National Family Planning and Reproductive Health Association, who are advocating at the federal level with CMS to try to have them influence states and have states have to make a policy change for this kind of thing. In addition, the Association of State and Territorial Health Organizations is out there providing technical assistance to states who want to make these kinds of policy changes. So far, Pennsylvania isn't far enough along on its path to be there, but we're staying in touch with them and hoping that we can get to this place soon. In addition, there are some interesting pilots happening in our region where one of our largest payers in the region, Keystone First, is piloting at some family planning clinics a kiosk, a cabinet of sorts, where a third-party vendor would stock and maintain LARC inventory in a locked cabinet, so the provider has no out-of-pocket costs for the device. All of this is happening between the vendor and the insurer. It helps ensure same-day access, and at this point, though, it's only available for use with that payer's members, and the vendor is currently working to expand it for additional kinds of payers, and so that more patients will have access to this. There's also another promising development in that last spring, a nonprofit pharma company, Medicines 360, with the backing of a large anonymous donor, launched a new IUD. That's available at 340B pricing of $50 for those entities that are doing public health work, Title X clinics, FQHCs, other public health providers. Now, this was a fabulous thing that was really lauded, but again, it was an enormous investment. Thank goodness we have a billionaire on our side, is all I can say. It was a huge investment as a workaround to some basic, easily solvable cost reimbursement issues. It helps the situation for some clients and providers. It's not a panacea. It's very early in the uptake of this, so not all formularies in all states have yet added it, and we don't yet know if the business model of this company will be sustainable over time, because they're basically selling some of these devices to for-profit companies to subsidize the public health reduced rates, and we have to see where that goes. Locally, after our July 2015 opportunity to speak before the Philadelphia Board of Health, there was a resolution passed supporting the idea of policy change to promote access, reimbursement policy change. Riding on the wings of that, we've had discussions with the state Medicaid medical director and, sorry, I keep bumping that, and meeting with Pennsylvania's Physician General to solicit support and help advocate. And I will say that during the last administration, we had talks that did not go very far, and that during this administration, we know we have several champions who really care about this issue, particularly in the context of adolescents. We have supplied them with the names of folks in other states who have done this work, who have made it happen, who can give them the logistics of making the systems changes that need to happen, and we're doing everything we can to move it forward. So, challenges. As I hope you have gathered from tonight, what we feel, most importantly, is that this is a situation where science is way out in front of policy. Challenges exist where we've got to reduce bias among providers, create an environment where they can really feel comfortable with LARC methods, especially for adolescents and women who haven't carried a pregnancy, which is quite a shift, depending on the age of the provider and their education. We want to ensure, above all, that we are doing this in an environment that promotes self-selection of the method. It is very, very critical to the work we do in Title X, but also to all family planning provision, that voluntariness is a key aspect of this. We don't want anything, in spite of our enthusiasm for the effectiveness of the LARC method, clearly it is every woman's choice what works best for her and for her family. And we want to reduce stigma and address community norms. There's still folks living out there thinking about Dalcon shields. There are still folks who are thinking, this can't possibly be a good thing to do for my teen. My teen will have sex earlier or more often if we have this kind of a method. And we know from research that that simply isn't true, and we need to address these issues. And obviously, as we talked about, there's the coverage and reimbursement challenges that continue. Very high upfront costs to a patient or provider. Certainly, while technically all methods are included, some insurers have really required, this is one of my favorites, some insurers were requiring women to show failure with a less expensive method first. Seems like a pretty risky situation to do that in. Failure's got some pretty long-term consequences in this case. And I think even for providers who have somewhat cracked the nut on reimbursement in their private practice outpatient settings, there are still issues around ensuring that all types of providers are recognized for putting in LARCs, that counseling is adequately compensated, and that the reimbursement is timely. Otherwise, it's very hard to keep these expensive devices in stock. There are also some issues around LARC coverage limitations within a certain period of time, and as we've talked a lot about denial of coverage for the inpatient setting. So how can policy change help? Obviously, one of the things that we're really concerned about is making sure that policies around counseling keep LARCs at the forefront as a really effective method, but also that all of this is done in a way that's voluntary. Oops. Oh no, see, now it's all gonna go bad. Oh, there we go, okay. No, did I do that right? Yes, okay. That it's voluntary, confidential, and patient-centered, and obviously implementing systems that support LARC provision. This reimbursement that we're talking about, approval for non-OBGYNs, and ensuring confidentiality. So as was mentioned earlier, making sure that any woman who wants this kind of method, and especially for teens, that they're not worrying that an explanation of benefits is going home that's going to expose the fact that they received this method. In terms of public perception, we want to fight misperceptions. IUDs are safe. They don't prevent a woman from getting pregnant when she wants to later. Teens are not more likely to have sex if they have a LARC. And as was mentioned earlier, we have high rates of continuation among teens and young adults, in spite of the fact that there is still a lot of talk out there about the fact that they don't do this. And now we have great studies to show that they do continue with these methods. We want to emphasize the benefits of LARCs, really expand general public knowledge of LARCs. Very few people, aside from us insiders, are talking about LARCs, especially in the context of teens. So we want to get involved at AccessMatters in public awareness campaigns. And in fact, today I'm excited to say we launched a new app called It Matters that you can now get on the App Store for free that will provide a lot of information about a full range of methods and hopefully will expand knowledge, especially to its target audience of teens and young adults, about the effectiveness of these methods, and obviously more community outreach. And why are we doing this? And why do we hope you're here tonight? Because we want to make sure that every woman who wants a LARC is going to have access to it, regardless of her income, regardless of her insurance status, and absolutely regardless of the setting of her care. We want to make sure, and we think one of the keys to this, our major initiative, is around state Medicaid reform that will mandate reimbursement without the need for prior authorization or post-insertion negotiation for the device, the insertion time for immediate postpartum insertion time in other outpatient settings where women want this, and counseling time. And I thank you for your time.
I know. Let me go back. There you go. Terrific. Can you hear us? Great. We'd like to take questions.
Excellent, informative talk. I have one other new development that also goes along with some of the things you've talked about. And I'd like to congratulate you and just say that because of the work that the speakers that we've heard tonight, because of what they've done, I want to tell you about another development that's happened in Philadelphia. Last May, a new project called the LARC Project was spawned out of the Penn Family Planning and Pregnancy Law Center. And the purpose of this project was not only to provide free of charge LARC to women who wanted them, but to do some of the outcomes research so that we can further the cause, to go to the state legislature and get additional funding. So because of this project and private funding, we are now able to say proudly that 2 of the 5 hospitals in Philadelphia where deliveries occur are able to offer to any woman requesting immediate postpartum insertion of an IUD to be able to have access to this IUD for free on demand at an appropriate time. And this covers 9,000 deliveries a year in the city of Philadelphia. So it's really having quite a lot of impact that we're seeing. And so I would, if anybody, my name is Ann Steiner, if anybody wants to know about the LARC project, I would be happy to talk to you afterwards. And again, congratulations on all the work that you're doing.
Thank you.
Good job. To get those newsletters, right?
Hi, everybody. Tom Farley, with the Health Commission in Philadelphia. So the project I've been interested in from before in New York. I got 2 questions for you. First is, for the hospital like Reproductive Schreiber that you were talking about that doesn't offer LARC postpartum now, if the reimbursement problems were solved, would the hospital offer it?
Yes, thank you for that question. But actually, so I need to correct if I gave misinformation. At the time that we produced those data, as you said, we were not providing immediate postpartum IUDs then, which is why nobody got one. But thanks to Dr. Steiner, Ann Steiner, who spoke right before you, and all of her fundraising efforts, and a couple of other supplies of IUDs that we've been able to kind of conjure up, we are offering immediate postpartum IUDs with great uptake and great success. And as Ann just said, we're following our patients longitudinally, so we'll be able to get some more of those data on expulsion rates, which are going to be very important as we hopefully scale up and are able to really do this across the country.
Great. So congratulations. The second question is a lot of unwanted pregnancies and abortion. And can whoever is the most expert of this answer questions about whether
Yes.
Oh,
Who
no,
wants
I
to
think
tackle
that's a
it?
clinician question.
Sure.
you want me to answer it?
Yeah.
You can do one part and I can do the other.
So I think that that's a great point, and thank you. So the point was that many unintended pregnancies end in abortion, and should we be providing post-abortal LARC as well? And I'll tell you that post-abortal LARC are way out ahead of post-delivery. One is not able to provide LARC after every abortion in every setting, in part because of issues with Title X funding, right? So in settings, for example, freestanding clinics that may offer abortion services in one half and have a Title X contraceptive and family planning clinic in the other half, you cannot cross over your contraceptive devices from the Title X federally funded clinic to the abortion clinic. Those have to stay separated. So there are barriers there as well. But before we were even as a country moving towards using postpartum LARC and specifically IUD insertions, there were tons of data published, and it was much more frequently addressed to provide IUDs and other LARC methods, implants as well, immediately post-abortally. So yes, it's important and effective, and thank you for bringing that up.
And I would say what I would add to that is that in addition to the importance of having it available for our adolescent patients, one of the challenges is definitely accessing care services. And so having challenges in terms of being able to access post-abortal LARCs in the clinics that we have to refer them to for their abortion services. One of the things that I've been doing in our LARC clinic at the Children's Hospital of Philadelphia is we basically get their LARC devices ordered at the same time that we refer them for their abortions, and then many of our patients will go get their abortion and on the same day come back to our clinic and get their LARC. So we've sort of found a workaround, but you are entirely right that finding a way to remove all of these various barriers can be really critical, and at the moment we have a workaround, but definitely removing some of these barriers would be definitely important.
About the technology and its cost, can one of you describe the piece? How many manufacturers are producers? Is competition coming, and are we likely to see some improvement on that situation?
So are we allowed to say the names of the manufacturers?
Here's Eileen.
So there is one manufacturer for the non-hormonal IUD. There is one manufacturer who makes 2 of the hormonal IUDs. There is one manufacturer who makes the low-cost IUD that was mentioned at the end of Melissa's talk. And then there is one manufacturer who makes the subdermal contraceptive implant. So there are a variety of manufacturers who actually produce these products. There are a number of additional devices that are in development, and I should probably let Corey answer that part because her group has been doing some of the research that's been demonstrating the effectiveness and safety of some of those other devices that are coming down the pipeline.
And I just wanted to add that with respect to the nonprofit developed low-cost device that I was talking about, its commercial cost is still consistent with the other manufacturers because they're not lowering that price because they want to use the profits from that to subsidize the $50 public health cost. And so that particular addition to the marketplace, while very good for public health entities, isn't driving down the cost generally of the devices.
It might though, because there is a sense, I mean, you bring up such a great point, and it highlights that there's nothing intrinsic about these devices that's expensive. They're not made of gold. They're plastic, and some of them have a little hormone in there. So they're actually dirt cheap to produce, and but lucrative. I mean, if you think about it, the other side of the story is that it's a one-time purchase. So birth control pills, you know, paying out of pocket for birth control pills is $50 per month. So even an out-of-pocket payer, while the upfront cost is high, the overall cost to her is not higher for a 5-year device or a 12-year device in the case of the copper IUD. But it's just a matter of being able to produce that cash up front. But the reason why the costs are high are, as you point out, because of lack of competition, and I think that will be changing soon. I know from the company that produces the two IUDs that have been marketed for, hormonal IUDs that have been marketed for a long time, that they feel a sense of pressure to bring down their costs a little bit. There's all kinds of negotiations going on there, and there are more IUDs on their way. A couple of the disclosures that I had were clinical trials for new IUDs. So there's a lot of momentum, which is great. I think in part driven by the increasing popularity of the devices and the great commitment to disseminate them widely.
I really appreciate this opportunity tonight to have this session. I'm fairly new to considering this issue. I'm a nurse, fairly new to considering this issue, but I really appreciate how you've laid it out and provided various facets and all the advocacy you've done. So my first question is, are your great presentations available somewhere through the College of Physicians or somewhere else?
Go ahead.
Okay.
We'll put them on Dropbox, and then this will also become a... Right.
Okay, so we go to YouTube to access. Okay, we go to YouTube to access the presentations. Okay. Thank you for clarifying. And so, Melissa, my question was about the Keystone First pilot. Could you say a little bit more about that? I didn't quite get it.
Yeah, and there are probably some folks in the room who can say even more because they've experienced it. But basically, it is a pilot where Keystone First, which is really one of the major payers in the region for services, so it's significant that they're doing it, contracted with a third-party vendor to make available a kiosk that would be fully stocked in the clinic. And the items in it would be barcoded. They could only be used for Keystone First patients. But essentially, the clinic isn't having to put any money out to stock LARCs in the clinic. This is all a transaction between the vendor and the insurance company. The kiosk is there full of LARCs for when anybody needs one. It gets accessed, barcoded, so that something goes back to the insurer saying this was accessed for one of your members. And it just eliminates that additional barrier. We've talked about a lot of barriers tonight, but it eliminates that barrier of practices having to put the money out up front, not being very sure when they're going to get reimbursed, if they're going to have difficulty negotiating with an insurance company, if there's going to be some kind of problem. And we always want to make sure that LARCs are available on site as much as possible so that when a client comes in, they can get same-day insertion if that's what they decide that they want to have.
Mm-hmm. And so I can tell you, practically speaking, I'll walk you through my day yesterday in clinic. So I had a 19-year-old patient come into clinic. She had been seen, and I should, sorry if I'm beating a dead horse, but I'm an OBGYN who only works in a children's hospital. So I was seeing a 19-year-old who had been referred from a community clinic where she had been counseled about her contraceptive options and was interested in using a LARC. She got referred to my clinic. We went through the counseling process, and she decided that she was interested in using the non-hormonal IUD, which works for up to 12 years. I then left the patient room, walked down the hall to the med room, opened the door. There was what appeared to be a vending machine, but instead of Coca-Cola and Doritos, I scanned a barcode. I pulled the device out of the machine. I went back to the room, and I placed the device in the patient, and she went home. What happens behind the scenes, so this is kind of an update for everyone up here, because since last July when we presented, I received a machine and I am now able to do what I just described, which is beautiful. But what happens behind the scenes, as Melissa was just describing, is that when I scan my barcode and put in that patient's name and information, a prescription for that device gets sent electronically to the third-party vendors, basically an outside pharmacy. It's a private pharmacy. They receive the prescription and fill it, and then they bill for that device to Keystone First, who they already have an established relationship with, such that everything that we take out of that machine for Keystone First patients is already covered at 100% no prior authorizations. So there's no cost to my clinic or the hospital for the device. It's all stocked by this private pharmacy, and they keep track of what we take out of the machine, and magically they know when the devices are running low and someone shows up and refills it. Exactly, hopefully. And then in terms of the billing, I then drop a bill for the actual insertion fee, which we know is covered at no cost. So I think the other thing that I'd like to point out is, why do I have this machine in my clinic? And I have this machine in my clinic because if that same patient had shown up and I didn't have this machine, I would not have been able to do that. So there are issues at the institutional level, because before a gynecologist was hired at the Children's Hospital, our hospital has no established relationship with any of the payers in the city for gynecologic services provided by a gynecologist or LARC services. So when I arrived, I called all the payers and said, here's what I do you cover it? And they said yes. And then I put in my first device and they paid it, and I put in the second device, and it's taken 14 months for them to pay for the third and fourth devices, because they had no contractual sort of arrangement with the facility to cover. And so in the meantime, we got this Pyxis machine, which has allowed me to be able to place these devices same day with no additional cost to my hospital for purchasing the supplies, and it allows us to make use of Keystone First's already existing policies to cover these devices.
And I just want to add that that particular MCO has an advocate for women and for teens, and who really felt like this was moving ahead of all the other MCOs. So the health department meets with the MCOs monthly, and we talk these through, and really she has been, Dr. Lily Higgins has been a step ahead. It takes a while to get these things done. I think she would have liked to have seen this done a year ago, but it's nice to have it there, and it's nice to have an advocate, and I think that they can also use this as evidence for how well it works and how well they're serving their patients and being able to reduce costs ultimately, which is what they hope to do.
And it'll build confidence, right? Because what this is working around is this issue of not having confidence in the payer situation, and also an established pattern of that. Across the street in the adult hospital, we have no problem. I have cabinets filled with outpatient LARC to provide. I never have an issue with that. So it's because we have that established track record and all of those contractual agreements all set. So just to clarify that it's not the only way, but in this situation, for now, it is the only way.
So this is all about policy and advocacy and making activists of all of us. So it would be helpful if you could come up with 4 or 5 things that we could all do. We have a way to get the email out to everyone that's here. And let's turn up the heat. I mean, this is not rocket science. And you guys know it works, and we now know it works. So let's make some changes.
Yeah.
Good.
Happy to do it.
Thank you.
And Pat is always looking to rile up the crowd.
Yes.
And we appreciate that. And you know, as we said, I think we also have a moment in time where you know, a couple of years ago, this was definitely pushing a boulder up a hill, and now the momentum nationally is moving in this direction. So we don't, you know, we don't have to say we're the first. We could say we're the 19th or 20th. And I think the administration, again, is full of folks who are generally supportive of this. I think it is exactly what you said, of getting it higher on the radar screen, making it clearer. And what we have found in our recent conversations in Harrisburg is it is also about continually backing up what seems like very obvious, apparent policy, simple policy, with what difference does it make from a cost standpoint. And as I said, I think for those of us who care about these issues for a variety of issues, that can be distasteful, but the numbers are there, right? The cost effectiveness numbers are there. The studies showing that this is cost effective in so many different settings for adolescents, for adult women, are there. And so we just keep trying to layer on and reinforce to the folks we're working with this information so that they're armed to make the arguments they have to within their departments to make this change. And I think having more voices to elevate that would be very helpful. So we'll make sure that we do that.
Thank you. Are there any other questions or comments?
Well, if I may, on behalf of all of us, 4 excellent speakers. Thank you very, very much.
Thank you very much. Thank you. Thank you.
I do have another question. Towards the beginning of the evening, we were shown slides about the disparity in teen pregnancy among Latino youth, Black youth, and then we heard about perceptions and attitudes towards LARC. And so I wondered if you've looked at research, if you've done the research to know about the differences between Latino girls, Black girls, white girls, and their attitudes towards it.
So why don't I talk about some of what's known from national data? And as I mentioned in my talk, AccessMatters has done a lot of work trying to address a lot of the attitudinal barriers sort of in the Philadelphia area. So I think there are a lot of attitudinal issues around LARC use that are not necessarily specific to adolescents, although there are certainly some issues that are particularly prominent among adolescents. I think Corey mentioned in her talk, sort of lots of people have this image about particularly IUDs that harkens back to sort of the 70s with the Dalcon Shield scare, where there was actually not an issue with the device itself, but with the string that was attached to it that allows providers to remove it. The material that it was made of could cause some problems or issues. But that really set us up nationally, where a situation where there was an increasing use of IUDs several decades ago, where that particular device then caused usage rates in this country to plummet. I will say that usage rates in other parts of the world, which I think none of us showed data on, are significantly higher. So in other parts of the world, these methods tend to be the methods that are primarily used as opposed to the shorter acting methods. And so women are fearful about whether or not these devices are safe. There's a lot of misperceptions about whether or not these devices cause infections, infertility, misperceptions that they're not appropriate for use in women who've either never had children or who are teens or younger. So I have a lot of, for example, moms who say, well, she's not old enough to use one yet, and I have to let them know if she's having a period, then her body is developed enough to be able to have one of these received. So there are a lot of different issues there. When it comes down to the adolescents, so a lot of them may have some of these particular issues or concerns in their heads. But there's another huge issue, which is that, so as I mentioned, there are some developmental considerations. So sometimes a barrier is just teens just in general for birth control don't necessarily think that they need it because it's not going to happen to them, or sometimes being a teen mom may not be perceived as being something very negative, sort of until it happens to them. And so cognitively, there's a lot of work to be done in terms of when we have our contraceptive counseling sessions with teens, it has a very different feel than our sessions with adult women. But another big issue is just the process of putting them in, particularly again for the IUDs. And so the slide that I showed that demonstrated that we are seeing an uptick in the use of LARC devices nationally is really great, but it's really taking off a lot more for the implant than the IUDs. A lot of young ladies that I see aren't sexually active and have never had a pelvic exam, never had a speculum exam, the device that's placed inside the vagina in order to open it up so we can see the uterus. And so they're really fearful that that's going to hurt. We have an ongoing study where we're trying to address some of these issues by looking at fear at the time of IUD placement and how we might be able to better address that. And then when you get above and beyond that, sort of those tend to be the most prevalent issues, and depending on the patient population, you may see some of these issues as more of a concern in certain patient populations than others. But really the big picture sort of attitudinal barriers are pretty consistent across patient populations.
I would also just add that there is I think a very interesting and sensitive discussion happening nationally now about the issue of reproductive coercion, which I mentioned in my talk. And I think, again, the science was out front, and there were a lot of funders, like the Title X program, like the CDC, who in the last couple of years have really been heavily promoting the use of long-acting reversible contraceptives and really trying to make sure that the word was getting out about their effectiveness and their safety, especially with respect to adolescent populations. And within my own organization, probably starting 2 to 3 years ago, we were having discussions that of really just the racial backdrop, the history that many groups, minority groups in this country have had around sterilization, around medical experimentation, around a number of things that promote an understandable sense of skepticism and worry about programs that could be seen as targeting low-income populations, which in our nation and certainly in our city are also primarily minority populations. And so it was interesting that the conferences I was attending 2 years ago were all about the effectiveness and the promise, and very little was happening at that level, at that high federal level, to discuss this very important issue around potential coercion or perceived coercion. And in the last, I would say, 9 to 12 months, there's been much more discussion about the need to really focus on the fact that this must be both factually voluntary and perceived as voluntary, or we will not get past community opposition. The folks need to know that this is one of many methods that, because effectiveness might seem like the logical, most important factor to birth control to me, it's not necessarily to everyone. Side effect, cultural differences, autonomy about being able to remove a device anytime you want or stop a method anytime you want might be more important to someone else. And that has been a mind shift that I was really excited to see at the National Title X Conference this summer. And I think there have been really important discussions and articles written about this by Guttmacher Institute and others. And if you're interested in that aspect, I would just, I would Google reproductive coercion and LARCs, and there's some really good dialogue happening nationally about this to ensure that even as we're making sure all populations have the knowledge and information and access to all methods, that we need to make sure we're doing it in a way that everyone is comfortable and feels fully informed and is able to make a decision that's right for them.
And just to tag on to that also, the teaching component of that's so critical. We emphasize continuation rates because of the need to emphasize the cost effectiveness. But the flip side of that is anybody who wants a device removed should get a device removed. I mean, these are reversible. So that's really key, but they're only reversible if patients can get them removed. So access to removal is just as important as access to having the device placed, actually. And we really emphasize that in our training clinics. I also wanted to just add on that for adolescents, in some ways, or young teens, the implant can be a perfect contraceptive device because it doesn't require a speculum exam or a pelvic exam at all, and we can just get rid of that whole fear factor.
And I want to just mention that the Philadelphia Board of Health was really sensitive to this issue when they created the resolution. Really, the idea was that if a woman desired this form of contraception, desired highly effective contraception, we in Philadelphia thought that she should be able to have access to that. Not that we should necessarily expect that every woman would want this form of contraception. And so we've worked that in throughout the Board of Health resolution with the support of the Board of Health. Are there any? Okay.
Hi, I have a question. It's a clinical question, but it's also an access question for adolescents. I see adolescents in the outpatient setting, and sometimes it's hard to quick start a method, and of course it's hard to quick start a LARC method, and it's hard to know when they're pregnant or not pregnant. What is kind of a practical way of defining whether a teenager is not pregnant? I hate sending people home on a less effective method to come back to get their LARC a few weeks later.
Yep. So I think there's two approaches. So one of the things that I've been training the various staff at clinics that recruit to us for, as well as my colleagues in the adolescent specialty clinic where I practice on, is at the time that they counsel an adolescent, if they're interested in a LARC, before they refer them to my clinic for a placement, because it's oftentimes two-step. I'm only one person in one particular facility. They have to make sure that they counsel those adolescents about making sure they engage in behaviors that will reduce their chances of pregnancy when they show up in our clinic, because we do have a number of young people who will show up, and when we take a history, they're high risk. So that's one, so anticipatorily ensuring that they're low risk. Two is the CDC has a publication called the Selective Practice Recommendations, and if you just Google CDC SPR, it comes up, and within that document is a beautiful algorithm laid out that helps you to figure out whether or not an individual may be at high risk for pregnancy at the time that they're showing up, which helps you to think about their pregnancy risk at that time, and if you can do a quick start. The reason why this question is important for the larger audience is that we generally will do, or we always will do a pregnancy test prior to placing these devices, but it's a urine-based pregnancy test, and those will not turn positive until approximately 2 weeks after an active intercourse where a woman could have gotten pregnant. So if a woman has had sexual intercourse in the 2 weeks prior and is pregnant, but is less than 2 weeks pregnant, at the time you see them, you can place a device, but then the patient can subsequently be found to be pregnant. So this is a really important issue. The third thing that I would say is that this is where something like the non-hormonal IUD can be fabulous, because if you have someone who has engaged in sexual activity where they're at high risk for pregnancy within the last week, if you place a copper device, it can serve as emergency contraception in addition to providing her with longer range contraception.
Are there any other questions or comments? I think that we are going to wrap up the discussion time. Dr. Schreiber is going to take us out with some final comments. And I really want to thank you. You've been a wonderful audience. Now, Dr. Schreiber.
First, I'd like to thank the speakers for really a wonderful presentation this evening. One nice thing about public health people is that they're passionate about what they do. And I think your passion came through in your knowledge as well. And I want to give you a round of applause for a wonderful presentation. I do have a few announcements I need to make before the meeting adjourns this evening. First, I would like to welcome Dr. Tom Farley, who is our new health commissioner. This is his second day on the job. I'm delighted that... I'm delighted that he had the time to come and visit with the public health community this evening. Tom is a pediatrician by training. He also has extensive public health experience being at the CDC and the health commissioner for New York City under Mayor Bloomberg. So we're delighted to have him come now to Philadelphia. And we're here to help you in any way that we can. So feel free to call on us. Next, I'd like to briefly tell you about our next citywide Philadelphia Public Health Grand Rounds, which will be held on May the 18th. And the title of the talk will be The Substance Abuse Epidemic in Philadelphia. And we've have 4 outstanding speakers. We have Dr. Charles O'Brien from the University of Pennsylvania, who will talk about drug abuse as a chronic disease. We have Roland Lamb, who is director of the Office of Addiction Services for the Philadelphia Department of Behavioral Health. He will be talking about the epidemiology of substance abuse in Philadelphia and how the city is addressing the problem. We will then have Dr. Douglas Marlowe, an attorney who is chief of science and policy for the National Association of Drug Court Professionals, and he will discuss the legal ramifications of drug abuse. And finally, we'll have Jose Benitez, who is the executive director for Prevention Point Philadelphia, and he will talk about substance use from the perspective of Prevention Point Philadelphia. So it looks like an outstanding program. I ask you all to mark your calendars and be prepared to come on May 18th for that presentation. I'd also like to take this time to thank the members of the staff of the College of Physicians for all of the work that they've done to make this event possible. And I can assure you that they've done a tremendous amount of work, so thank you for that. I'd also like to thank the Pennsylvania Medical Society and the Philadelphia County Medical Society, and especially Eileen Ryan, for making it possible for us to offer CME credits for this presentation. Now, in order for you to get the CME credits, though, you are going to have to complete the evaluation forms, which were given to you at the beginning of the meeting, and I urge you all to complete these evaluation forms and turn them in so we can evaluate the presentations. And finally, for those of you who are not active members of the section of public health, I would encourage you to join. I believe we do have outside information about how to join the section. So that concludes the meeting for today, and now let's take a break and do some networking and just enjoy each other's company. And thank you all for coming.
CLEs.